Okay, let's finish up with obstetrical emergencies, specifically shoulder dystocia, and its difficulty is the word dystocia, with the shoulder coming out. And after the birth of the head, now just think about this, the baby's stuck. And if his head is out, but his body, specifically the anterior shoulder, cannot pass, we're just, counting the seconds to get this kid out before what the placenta shears away or separates from the endometrial lining inside. So it is an emergency, as you can tell. We can change mom's position. We can apply suprapubic pressure to the anterior shoulder on top of mom to push it out from under the symphysis pubis. You'll see that done. We see pictures of McRoberts maneuver, and the mom is almost like an acrobat. Her legs are flexed to where her knees are on the abdomen or in her armpits. We've seen that before. And so what happens, the symphysis pubis is rotated toward the mom's head to open up the outlet. Sometimes you put them on hands and knees, squatting, sometimes with the squat bar. And we do not and should not apply fundal pressure, because if you apply fundal pressure, we can have what we call uterine rupture, which we'll see a little later in terms of the discussion. Never want to do this. Secondly, we hear, and just remember, we've talked about this before, prolapse cord. Prolapse, basically the cord is like coming out of, prolapsing out of the cervical ring. Maybe it's a little bit out of the vaginal opening or completely out. Cord lies below the presenting part of the fetus. Now think about this. Again, kind of like shoulder dystocia. The baby is not out yet, but the cord is, and we're waiting eventually for that placenta to come off. So it's a matter of minutes. This, again, is an obstetrical emergency. And so we're saying a cold, it's hidden with or without ROM, or it's frank, it's visible after the ROM. And you might want to say, how can that happen? How can it just gush out? Isn't the baby's head down? And for the most part, when we have baby's vertex, we don't see it that much. However, we talked about the breech position, because basically the baby's head is like a cork. And in the breech position, his head is up by the fundus. And we have the little small bottom. At the time of ROM, due to gravity, when the amniotic fluid flows out, the cord flows out because there's no cork. There's no head to stop it. So we're looking at many different, here's the breech, a lot of etiologies, but you can see how it occurs in breech. You can see how it occurs in many babies inside. The mom with maybe multi-gestation, or moms who have multi-parity. This is the 10th baby. So everything's stretched out, or the head is big, or the baby's small. So, or transverse lie. There's nothing literally clearly we call corking up that hole down there. So that's not good. Feeling the cord is seen or felt or protruding from the vagina, this is not good. We're going to see cord compression. We're going to see deep variable decels. We're going to see the baby gets hypoxic. First tachycardia, because he's not getting enough O2. Late sign Brady. Then deep variable decels, and then going to late decels. So that's not good. What are we going to say? It's going to see in the book, read your book, and it says prompt recognition, and we want to hold the presenting part off the cord. So typically moms are lithotomy or low Fowler's position, and when the baby's coming out, typically if it is a vertex or a breech, the cord is usually coming out from the posterior side. Posterior, because the gravity is pulling it behind the baby. So, and the baby is usually on top of the cord. So you got the baby, then the cord coming out on her posterior side. So what we're going to do is literally hold the presenting part off the cord, which is usually on her posterior side. And you can wrap in sterile dressing, but what is the primary nursing intervention? To hold that presenting part off the cord so the baby can get the O2. Slap on the O2 on the mom, opening up the IV. We can actually monitor the baby, but what they usually do is they hold the presenting part off the cord and they run to the OR and they section the baby. If it's just a little bit coming out, we can have her knee chest. You'll see the pictures, or Trendelenburg, to get that presenting part off the cord. Very, very important. So always relate your fetal monitoring strips with what's going on here. And then rupture of uterus, not common, but can happen. Obviously, a high mortality rate for mom and baby. Typically, we see, which is we see here before, is that, you know what, typically the providers will not do a VBAC. They will not do a vaginal birth after a C-section, specifically one with a classical cut, a vertical cut. We see them in trauma, and we also see them in too much Pitocin, that it's way what we call hyperstimulated. They will see, unfortunately, see that in very rare cases. So we can say that there's complete and incomplete, meaning how far does this baby go out? Is the baby all the way out the entire uterine wall and in the peritoneal cavity? And I can imagine there'll be no what? The mom will be in huge amount of pain, and there'll be no uterine contractions. If you look at the EFM, the fetal heart rate's gone, no fetal heart rate, and no contractions on the monitor. And then at that time, you'll get eventual placental separation. This is not good. This is she goes into shock. So the best treatment, they say, is what? No VBACs. We talked about that a lot. We're talking about shock and medical management. It depends on what severity. We're going to see if incomplete rupture, they can do OR, birth the baby, and repair the laceration and blood transfusion. And if it's incomplete, we can do a hysterectomy, because basically the uterus is basically ruptured. Blood transfusion. So incomplete when it's not all the way out, and the baby is not showing any non-reassuring signs. So there's a way to save it, and we can try to birth the infant. So lots of internal bleeding, major abdominal trauma. You can just imagine. IV support, blood transfusions, usually she becomes a surgical case. And of course, psychosocial support. Lastly is amniotic fluid embolism. And they call them AFE, amniotic fluid containing particles of Vernix. Maybe it's lanugo. It can eventually go to the pulmonary vessels, causing immediate respiratory distress and circulatory collapse. You remember I talked about Kim Kardashian, and she had the issue of accreta, placenta accreta. I always, think of the people in pop culture. Now think of the tennis player, Vanessa Williams, and think of her, or is it Serena Williams? Maybe Serena Williams. And she had thrown at a PE, maybe not an AFE, but a PE postpartum. And if you read it online, I would say in a mild form that a lot of people didn't believe her, that they said, oh, she's in pain, she's breathing a little harder than usual. Well, actually, she almost died. She could have died from a PE, and you can imagine the mortality and morbidity on top of that is just so horrendous. So it's something to look out for. Obviously, it's not common, but if it does happen, just like a PE and med-surg, it's horrible. It's immediate response is required. What happens? And I talk about it sometimes in labor delivery. When you see a tumultuous labor, when you see a precipitous birth, when you see someone on cocaine and it becomes strong, hard, fast labors, where the placenta abrupts quite quickly, because abruption occurs when the uterus is contracting hard and fast, hyperstimulation, too much Pitocin. If you think about it, if rupture occurs, and all this kind of makes sense in that there's so much tumultuous things going inside that uterus that it's kind of understandable that some of that baby's circulating Vernix and lanugo in the amniotic fluid re-enters the uterine arteries and or the vessels and return back to mom. So it's unfortunate, but it can happen. And this is just a touch on med-surg, and med-surg will teach a lot about PEs in third and fourth, but you can imagine having a piece of Vernix in your pulmonary bed. or Lunigo in your pulmonary bed. That would be respiratory distress, venospasm, hypertension, pulmonary hypertension, and possibly respiratory arrest, circulatory collapse, and hemorrhage, and DIC. So review these and just a picture in your brain of that happening physiologically, and just graphically just map it out in your brain. And you can see why it's left ventricular failure. And you can see why, because there's no blood coming out, right? It's just totally collapsed. And hemorrhage is trying to clot off this big clot. And then she uses what we call overconsumption of clotting factors, and she goes into DIC. O2, of course, and it can intubate, mechanically ventilate, CPR if necessary, if she goes into respiratory and cardiac arrest. Put her on her side, avoid supine hypotension, open up the IV, LR only, no normal saline, get the pressures back up. And if she's in DIC, it all connects. We're going to give her what? Blood components, RBCs, packed RBCs deliver O2, fresh frozen plasma. Plasma delivers the factors that create clotting. And we're going, and then also it's a little more advanced thinking, but they have cryoprecipitate in the fresh frozen plasma, which helps with clotting. And Foley, of course, to what? Decrease the bladder distension so she can involute, so she can contract, so the uterine arteries can be compressed. Correct coagulation failure, NST, check the baby. Poor baby, right? Prep for emergency childbirth, usually a section, and psychosocial support. So for these moms, we see the moms ending up in ICU, hopefully surviving, but some of these moms do not survive. All right, that's it, and that's enough. Thank you.